welcome to the latest episode of Cancer Immunotherapy and You Patient Education Webinar Series. I'm your host, Dr. Ajit Muley. The topic of today's discussion is Unlocking Innovations. Stay current with the latest in ovarian cancer management updates. Today we have with us an eminent expert in the field of ovarian cancer treatment, Dr. Dimitriy Zamarin from Icahn School of Medicine at Mount Sinai. Dr. Zamarin is Professor of Hematology and Oncology and Section Chief of Gynecologic Medical Oncology. He is also a member of Precision Immunology Institute and Icahn Genomic Institute at the Icahn School of Medicine at Mount Sinai. Welcome, Dr. Zamarin. It's lovely to have you here today.
Thank you.
Let's jump straight in. What is ovarian cancer? Are there different types of ovarian cancers?
Yep. So ovarian cancer is the cancer that develops in the ovaries. Normally, these are the organs that produce the eggs that we need for reproduction. But unfortunately, some women do develop cancer in these organs. And this cancer may derive from different cells that may reside in the ovary. And as a result, as you have mentioned, yes, there could be different subtypes of ovarian cancers that women may develop. And there are some of these subtypes can present in the earlier age. Most of the ovarian cancers that we see are actually cancers of older women. So for example, the most common type of ovarian cancer is called high-grade serous ovarian cancer. In general, that presents in the older female population. There are some exceptions specifically for women who carry certain mutations. For example, mutations in BRCA1 or BRCA2 gene. These women may be at a high risk for developing that cancer earlier on. There are also other types of cancer that we see which are more rare, like there's an example of a cancer called clear cell carcinoma or endometrioid carcinoma. These tend to be more related to endometrial cancers actually, and they may arise as a result of endometriosis. It's essentially endometrial cells that seed the ovary or even the peritoneal cavity, and those also later in life may lead to development of cancers. And then there are other kinds of cancers that look more like gastrointestinal malignancies, such as mucinous carcinomas. Those are also very rare, but nevertheless, we do see a fairly large proportion of women who have these types of cancers as well.
Sure. Yeah. So what I'm hearing is it looks like women from all ages can actually are at a risk. So are there any markers that we can test, screening or diagnostic tests?
It would be fantastic if we had some sort of screening tests to detect ovarian cancer early. And in fact, a number of very large prospective trials have been performed to determine whether early detection strategies, such as, for example, through use of ultrasounds or certain blood markers like CA125, can, first of all, help detect cancer earlier, but secondly, to help these women live longer. And unfortunately, none of these trials have been successful, meaning that the trials have perhaps demonstrated that there may be a small subset of women in whom the cancers could be identified earlier, but this did not result in the overall improvement in survival. Why is that? Well, unfortunately, this is because this is very much linked to the biology of ovarian cancer. Unlike many other cancers like breast cancer, which starts as a small focus and then it grows and then it metastasizes to lymph nodes perhaps, in ovarian cancer, the evolution of cancer is a little bit different. These cancer cells kind of start spreading as soon as they develop. So these sort of microscopic cells, or sometimes even precancer cells, may spread to other areas and sit there and then develop into cancer. So as a result, the majority of ovarian cancers that we detect, in particularly this high-grade serous type of ovarian cancer, is detected at the higher stage, stage 3 or stage 4. And this is why the screening tests to date have not been successful, because we have not really come up with a good strategy yet to identify the microscopic disease before it escapes.
Are there certain women that are more prone to having ovarian cancer? Like, what are the factors that might lead to this?
So there are certain types of mutations or germline mutations that women may carry in their family that may sometimes increase the risk of ovarian cancer. The best studied of those, and those are the ones with the highest risks, are mutations in the genes known as BRCA1 and BRCA2. And these women are predisposed to developing ovarian cancers and breast cancers as well. So for women who have a strong family history of breast and ovarian cancers, particularly at a young age, we always recommend to undergo genetic screening. And for women that do have an identified mutation in these genes, it is very important to talk to the physicians about the, first of all, early screening strategies, which may involve more frequent examinations, but more importantly, risk-reducing surgeries. And for example, for women who are done with childbearing, and it has been demonstrated that risk-reducing surgery, meaning removal of the ovaries and the fallopian tubes, can substantially reduce the risk of development of ovarian cancer. This is the only sort of population where we think we can make a meaningful and sort of an impactful contribution to survival by not just identifying the cancer early, but hopefully catching it before the cancer even develops.
Just going back again about the diagnosis, what are the diagnostic tools that are available right now, as you were saying about early screening, if it is possible for high-risk patients?
So again, as I mentioned, unfortunately, there is no early screening tool. And the most common way that this cancer is identified is women may develop very vague symptoms such as abdominal distension, bloating, abdominal pain. They may, they commonly go to different physicians to try to figure out what is going on. They may have seen the gynecologist, and it's not always apparent on the gynecologic exam whether something is abnormal or not. But the typical workup is essentially the same in most of the women. There could be an ultrasound that's done that may identify an ovarian mass. If somebody has more vague types of abdominal symptoms, usually it involves a CT scan that may show that there are certain organs that are involved. And again, typically this cancer spreads through the abdominal cavity and as little implants that may be present on abdominal wall or intestines or other organs. And typically a CT scan or MRI may demonstrate the presence of such implants. Yeah.
What are the other treatment options for patients who have been diagnosed with an ovarian cancer?
So once someone has been diagnosed with ovarian cancer, the treatment depends on, first of all, the type of ovarian cancer that they have, but secondly, on the degree of spread that the patients may have. So the typical approach to ovarian cancer involves either surgery to sort of what we call debulk or cytoreduce, remove as much of a cancer as possible, or in some cases when the surgeon does not feel like they could substantially remove the majority of the tumor, we start with chemotherapy. This would be what we call neoadjuvant chemotherapy. So the goal of the chemotherapy would be to reduce the disease burden, then for the surgeon to go in to perform the operation. And then the patients get more chemotherapy afterwards. This is the sort of most common type of therapy that we have in ovarian cancer. And it's so for the majority of what we call epithelial ovarian cancers, such as high-grade serous, endometrioid, and clear cell, that's the approach. And again, this is predominantly for the patients who have stage 3 or higher disease. As I mentioned, there are some women that may have earlier stage cancers, and that this is more common with clear cell cancers as well as endometrioid cancers. These patients might not require as extensive of a surgery, and some of them may even forego chemotherapy if we think that the disease is low enough risk. Unfortunately, that's the minority of women.
We are talking about personalized treatments. as we see, there are so many different types of ovarian cancers. Are there personalized treatments also available for patients?
Yes, so because there are different types of ovarian cancers, as you have mentioned, some of the treatments can be tailored to the specific ovarian cancer subtypes. So again, as I have mentioned, this high-grade serous ovarian cancer, which is the most common one, it may be frequently associated with mutations in genes like BRCA1 and BRCA2, and it has been demonstrated that certain classes of agents, such as platinum therapies or PARP inhibitors, may be more effective in these patients. So while everybody will get a platinum-based chemotherapy in the upfront setting, we know that the patients specifically that have the BRCA1 and BRCA2 mutations or related tumors that might not have these mutations but still exhibit very similar defects in the DNA repair known as HRD or homologous recombination deficiency, we know that these patients may be more likely to benefit from subsequent PARP inhibitor therapy. And in fact, this is what these patients get. After completion of upfront chemotherapy, they may get this type of a PARP inhibitor maintenance. And that has been demonstrated to substantially delay the disease from coming back. And in the BRCA mutated patients, patients with BRCA mutated tumors, we think it may actually improve survival as we're now getting the data 5 and 7 years later after the initial clinical trials have been conducted. There are some other biomarkers that can be used to identify patients for certain types of therapies. For example, over the recent number of years, we have seen development of what we call antibody-drug conjugates across a number of different cancers. In ovarian cancer, one of the common markers that's actually expressed on the surface of ovarian cancer cells is called folate receptor alpha, or FOLR1. There is an antibody-drug conjugate, or ADC, that has been developed for that. It's called mirvetuximab. And for patients whose tumors express these markers, this drug could potentially be beneficial. In fact, it has shown to be beneficial, although in a later line setting. And some of the clinical trials right now are starting to explore whether incorporation of that drug into an earlier line setting may benefit potentially even a larger number of patients.
So we hear a lot about immunotherapy and CAR T therapies and stuff like that. Are there any immunotherapies available for ovarian cancer patients?
So unlike many other cancers, we unfortunately don't yet have an approved immunotherapy in ovarian cancer. And by immunotherapies, I'm at first referring to the type of therapy known as immune checkpoint blockade. Those are the antibodies that activate sort of patients' endogenous immune cells called T cells to help them recognize and kill cancer cells. So these types of drugs have been approved across a number of cancer types, of course, melanoma, lung cancer, kidney cancer being the prime examples. In ovarian cancer, we have conducted a number of clinical trials with these agents, and unfortunately, the percentage of patients that benefits from these drugs is substantially lower. Now we're starting to understand that the ovarian cancers, because of being very genomically complex, they develop a number of mechanisms that help them escape from the immune response, which may make them more resistant to these types of therapies. But, with more research, we're hopefully starting to see more successes. So over the recent years, we're starting to see a number of clinical trials using sort of next generation immune checkpoint inhibitors that may be showing some benefit in these patients. Combinations of immune checkpoint inhibitors with other therapies, whether this is chemotherapies or targeted therapies, that may also be beneficial. But then other therapies as well, which are not checkpoint inhibitors, a good example being CAR T cell therapies. CAR T cells are, of course, the engineered T cells that are designed to sort of recognize a certain protein on the surface of cancer cells, and these are approved against lymphomas and multiple myeloma, mainly liquid malignancies. But now newer evidence seems to indicate that some of these could be beneficial in solid tumors as well. And at least a couple of studies that were presented or published last year have demonstrated that they can be beneficial in ovarian cancer. For example, a special type of CAR T-cell therapy called TRuC therapy targeted against mesothelin has shown to be beneficial in ovarian cancer. There was a paper published in Nature Medicine last year. And smaller trials that have used CAR T cells targeted towards some of these proteins expressed by ovarian cancer cells, such as Claudin-6, have also shown some promise. And I think while I don't want to overemphasize the potential impact of these types of therapies, I think this is a good indication that ovarian cancer can be susceptible to immune-mediated types of treatments, and I certainly look forward towards further development of these types of drugs in the near future.
And solid tumors are something that are always been enigmatic in terms of immunotherapy and how effective they are for immunotherapy. So I just wanted to ask you, what makes solid tumors so difficult to treat with immunotherapy?
Sure. So the solid tumors is a term that probably encompasses a huge variety of the different cancers. And we know that some solid tumors are very susceptible to immunotherapies. Again, speaking about immune checkpoint inhibitors, cancers like melanoma, renal cell carcinoma tend to have more susceptibility to immunotherapy than perhaps other cancer types. I think part of the problem that we see with the solid tumors is that they're very genetically complex. They take many, many years to develop, and over this course of the cancer evolution, genetic cancer evolution, while they acquire all of these different mutations, these cancers, of course, also have to overcome the immune pressures from whether we're talking about the local environment, but also the immune pressures of the host as a whole. And in fact, the cancers that we're seeing, or the cancers that actually developed, is a product of this evolution. Most of us are probably developing cancer cells throughout our lifetime, and these are eliminated. So essentially what we're seeing that actually emerges as a cancer is evidence of what we call immune escape or immune editing. That basically means that the cancers that we observed have already gone through so much immune pressure that they have acquired mechanisms that enable them to avoid the immune system. And as a result, when we apply immune types of therapies, these are not always beneficial for these types of cancers. I'm not going to say never is never, because we know that while one type of immune therapy might not be effective, perhaps a certain types of combinations may be effective for these patients, or perhaps by identifying these mechanisms of immune escape that the cancers have generated, we will be able to target these mechanisms. And I mean, we're starting to understand that these mechanisms are not uniform across all patients. Like, we cannot give PD-1 inhibitor to every single patient and escape that these will work in every patient. So it is likely that some patients may require one type of therapy while others may require another type. So and we're still, I think, at the very beginning of trying to understand of how the different types of cancers, or even within one type of cancer, how different types of genetic variabilities may impact the immune recognition. But I think we're well on our way.
We hear that you are also conducting some clinical trials. So are you working with immunotherapies with your patient?
Yes, it's immunotherapy specifically is an interest of mine, both in the clinic and in the laboratory. So again, in the laboratory, we try to understand why ovarian cancers are resistant to immunotherapies and use preclinical models to develop new therapeutics. In clinic, we take advantage of some of these novel types of therapies to apply them to patients, again, either alone or in combination with the standard treatments. For example, as I have mentioned, some of the emerging drugs in ovarian cancer are antibody drug conjugates, and these can be applied across a number of different surface proteins in ovarian cancer. So we have some clinical trials with antibody drug conjugates that either already ongoing or in development for ovarian cancer. The other class of agents we haven't spoken about is a bispecific antibodies or bispecific T-cell engagers. Those are, again, types of therapies that are designed to bring T-cells, the immune cells that kill cancer cells, to your cancer in order to mediate the cancer killing. Very much like what a CAR T-cell therapy does, but this does not require collection of T-cells from the patients. And we have several clinical trials that are currently in development to apply these towards patients with ovarian cancer.
That's wonderful news for all the patients who are suffering right now. Any last words, sir, for our patients? Anything that you would like to say in terms of diagnosis, screening, preventions?
One of the things that I want to emphasize is participation in clinical trials. I think there is a common misconception that clinical trials are only for patients who have already exhausted all types of standard lines of therapy, and we always encourage patients to inquire about standard or about clinical trials much earlier on.
For patients who are really interested in participating in these trials, are there any resources available?
There are actually quite a few resources. Clinical trials are good and bad. They're good in the sense that, of course, they can improve the care for patients, but they're not always available at every institution. And it can be daunting to look for these and to understand what is the best trial that may be appropriate for a specific patient. I mean, we always encourage the patients, of course, to talk to their physicians and to see what trials are available in their institutions or in the area around them. But then there's some other resources on the web that are available to patients that may help patients identify certain studies that maybe even their physician might not know about. So Cancer Research Institute actually has a very nice website that goes into explanations about the different types of immunotherapies, what immunotherapies are maybe available, but also specific cancer types and the clinical trials that are available for these cancer types. For ovarian cancer specifically, the Ovarian Cancer Research Alliance, or OCRA, also has a very nice website that provides links to specific clinical trials and also has information for the patients and their caregivers with potential connections to the resources they may need throughout their cancer journey. The clinical website or the trial website that we commonly use as clinicians is clinicaltrials.gov. This is probably the most comprehensive collection of all clinical trials for all cancer types, and this one can be searched again by types of therapy, by the cancer type, but also by location, and they provide information for whether the trial is still recruiting or not recruiting. That site may be a little bit more difficult to operate for patients that might not be familiar with certain terminology, but if somebody wants a very comprehensive listing of all of the clinical trials, this may be a good site to go to as well.
Lovely. It was nice chatting with you, doctor, and thank you so much for the information that you have provided to us and other patients. Thank you so much.
Fantastic. It was a pleasure chatting with you as well.
Thank you.